Hello, ladies. Tabby here. Just sitting down to walk through some pediatric assessment with our team at Same Day Surgery. The goal of this presentation is really to increase our confidence level in taking care of the pediatric patient in a same day surgery setting. So, some of this information is going to be information you already know, some of it might be a refresher, other parts of it might be completely new information. But the goal remains the same to increase our comfort level in caring for the pediatric patient in a same day surgery setting. So, what we're going to do today is walk through how do we approach children, how do we take care of a child in a manner that's developmentally appropriate for that child, understanding what their fears or concerns might be developmentally based on their age and stage of life, as well as just reviewing pediatric assessment. One of the most important things for us to remember is that kids are simply little grown-ups. Their bodies are going to function relatively the same way. Their lungs are going to be the same as a grown-up lung, their heart, their GI system. But there are some things that we want to take into account for the pediatric client as they are growing, as their bodies are changing, that might be slightly different. And so I think always it's important to remember they're just little grown-ups, and we've got to learn how to come alongside them, partner with their families to help them feel the most comfortable. And I think the first step in that is helping our nurses to feel comfortable in caring for these clients. So we're going to jump through this video today. I hope that it's an encouragement to you guys and that it's helpful. And as always, please feel free to reach out to me with any questions or concerns. At the end of this video, basically what we'll be doing is having some Q&A sessions that we will set up at a variety of times where you guys can come in and ask me your questions. We can review information from this assessment video, all with the goal of helping us to feel more comfortable with children in the same day surgery setting. So, goals of a pediatric assessment. One of the biggest things is trying to avoid or minimize the stress and anxiety associated with assessment. Children are in a new environment, they're in a new place. Many times they don't necessarily understand what's happening or why it's happening, and they have a hard time rationalizing that. And so, there's a lot of fear that comes with them in any medical environment or any environment that is out of their norm. And so our big goal is going to be to do everything in our power to minimize the stress and anxiety that these children have in our setting. The first step of that is really fostering that trusting and relationship with the nurse, with the child, and with the parent. When we're working with peds, it's very important to remember that the child is not our only patient, but now we have a couplet or a thruplet, I guess you could say, a triplet, where we have the child and their parent or their caregiver or their grandma, grandpa, whoever's there as their support person. And we need to be building that relationship with the child, but also with the family, because if mom and dad feel comfortable and they're projecting comfort and peace in that situation, that's going to help to reduce the child's anxiety as well. Allow for the maximum preparation of the child. We want our kids to be as informed as we possibly can, to the point that it's developmentally appropriate. That preparation piece really comes in a lot with the child life specialists and the children 3 and older who are really able to understand what's going on. They will handle a large portion of that. But the more that we can share, just like we do with our grown-up patients, about what they can expect today, what it's going to look like, reassuring them that mom and dad are going to be there with them as much as possible, that will help them to feel more prepared for their procedure that they're having done today. Obviously, preserving security in that parent-child relationship. We are the bad guys, not mom and dad. And so it's always really important when we're doing things. That sounds terrible to say it that way, but especially in like an inpatient setting, we would always tell mom and dad, you know what, you are the safe place, you're their safe space, and we're okay being the bad guy if we need to be for a medical thing to be done. It's okay for them to be mad at us, to take the Band-Aid off, to put the oxygen on. to hold their arms still while we're doing a blood pressure and they're mad. We want to preserve the security of the parent-child relationship. And so if mom and dad are comfortable doing those things and they feel fine with that, obviously we want to involve mom and dad as much as we possibly can, because that's going to help that child to feel more comfortable and more confident. However, if it's a situation where mom and dad are just not feeling comfortable, an example, Kat had I believe she was a 4-year-old little girl that came in for an MRI, and we were going to need to give her Versed because she just would not calm down in order to really do any type of assessment or care of her. And so Kat grabbed me, and together we were going to go in and give this little girl oral Versed because the parents didn't necessarily feel comfortable giving that medication to their child. Now, Versed's kind of an extreme one. That's a pretty strong medication, but that can sometimes be true with Tylenol, with ibuprofen. So I always ask the question, so this is what we're going to do, mom and dad. Do you want to do it, or would you like me to do it? And kind of provide them that opportunity to make that decision while at the same time preserving that parent-child relationship. And then obviously doing everything we can to maximize the accuracy of our assessment findings. And so that might be holding that child's arms still, trying to use distraction when we are, putting stat probes on, trying to find things that might calm the child down in that moment so that we are better able to assess them in a way that's going to give us the results that we need. So we're going to use a 3-step model today to talk about assessing children. And the reason that we're using this is because this is what they use in PALS. And so anyone who is going to take a PALS course, which it sounds like the majority of us eventually at some point will, I want to use the same model that PALS is using so that this is information and terminology and a process that we're already familiar with and already utilizing, which will make that much easier when the time comes. So you'll see this is similar to ACLS. Actually, it's identical to ACLS. We follow the same models in pediatrics. You have your primary assessment, your secondary assessment, and then all of your diagnostic assessments. And so this is the model we'll be using: evaluate, identify, intervene, and it's a continual cycle that just keeps going. This is nothing new to us as nurses. This is what we literally do every single day. We're just going to be learning it in the context of children. So first step is our initial impression. Initial impression uses an A, a B, and a C, but they're not the A, B, and C we're used to. And we're going to talk about that in a moment, but essentially your initial impression is your view from the doorway. This is before you are hands-on. There is no stethoscope in your hand. You walk in the door, and in that snap 15 to 30-second window, your nursing judgment is clicking in, your nursing goggles are on. What am I observing about this situation and about this child before I ever get hands-on to do an assessment? So I like to think of this as the view from the doorway. And so there are 3 components to this. You have your appearance, and we'll go through what we're looking for in each of these in just a moment. Your appearance, how is this child looking? Your work of breathing, and your circulation. All of this is completed within the first few seconds of encountering a child. So the first step is appearance. What can I see from the doorway? What do I see about their level of consciousness? Are they alert? Are they awake? Are they lethargic? Are they comatose? Are they sedated? What am I noticing when I walk in the room? And then eventually that's going to lead us to asking questions about, is this developmentally appropriate for this child? Or is this child's baseline? Especially with our Dr. Murphy patients and those Botox injections, we're getting a lot of brain injured children. And so it's really important for us to understand what is normal for them, but that first is going to start with us recognizing what is different than we would expect for a child this age. The next thing we look at for children is their ability to interact. So how are they interacting with their environment? Obviously, a younger child in a new environment, there's a lot of things they've never seen before. We're going to expect one of 2 things: either that they're going to be scared and they're really leery of you and unsure of what's going on. They might be crying. They might turn away from you. That would be an expected interaction with an environment that child is unfamiliar with. The other expected interaction would be interest. Man, there's a lot of cool buttons around here, and there's a lot of fun flashing lights and all sorts of little stickers and things I've never seen before. I want to play with those. I want to put those in my mouth. I want to know what this is all about. So, how are they interacting with their environment? Now, if we walked into a room and there was a 2-year-old child who was just laying there limp and lethargic, and they really didn't have a care in the world, and we just put the blood pressure cuff on and we put the sat probe on, and they're not flinching, they're not looking, they're just kind of like hanging there like a limp little rag doll, that is not a child who's interacting appropriately with their environment and would lead us to believe, man, this child might be sick. They're probably not feeling well. I need to investigate in this. Basically, what we do with children is we use this acronym called TICLES, TICLS, and that helps us to assess really level of consciousness. What is their tone? Are they hypertonic? Are they rigid? Are they hypotonic? Do they have normal tone? How are they interacting with their environment? Consolability. Are mom and dad able to console them? We see this oftentimes in the post-operative side when they are still in kind of that funky stage with anesthesia. There's a name for it, and of course I cannot think of the name for it right now in children, but essentially where they're completely inconsolable because they do not understand what is happening. They do not understand what they're feeling. They can't rationalize, I took this medication and therefore I'm feeling this way. And so they're inconsolable. If we're noticing that outside of that context of that immediate postoperative period or post-anesthesia period, inconsolability can lead us to believe that there's maybe a neurological thing going on or that this child's in a lot of pain. And sometimes that's the catch-22 of post-op is this anesthesia that's causing this child to be inconsolable, or is this a child who's in pain? And then we need to take into account the type of procedure that they had. It's not going to hurt to give them a little bit of ibuprofen or to give them a little bit of Tylenol to see if that might help them, or a little bit of fentanyl in a PACU setting for those working at the OSC, to give them a little bit of fentanyl to see if that maybe will calm them down and help. But inconsolability can point to something neurologically going on, which could be a sign from those anesthesia medications that I'm just feeling really funny and I don't understand what's happening and I'm mad about it. Or it could be pain. And so we needed to pay close attention to that. The other one is just that look, gaze, and stare. Are they looking around? Are they checking things out? Are they kind of like gazing a little bit, like they're a little out of it, they're a little sleepy? Or do we have a fixed stare that's not moving? And that's probably something we're going to see a little less frequently in our environment, but definitely something to take into account. The last would be their speech or their cry. Are they using a metered speech, which I'm having a hard time breathing? Okay, that's giving us an indicator that they can only get 1 or 2 words out before they need to take a breath. That can be an indicator that a child's having a hard time breathing. Is their speech developmentally appropriate? Or do we have a high-pitched shrill cry, which is often an indicator of something neurological or lots of pain? So what does that look like? All of those things, that Tickles assessment is going to give us an indication of where we're at level of consciousness wise in our children. We can't just walk in and be like, so are you alert? Are you awake? Can you tell me your name? Do you know where you are? What day is it? Who's the president? You're not going to get a lot of children who can answer that appropriately. And that's why we use this Tickles assessment in order to assess those things. Now, obviously contingencies, this I made this for my students, so some of these things you guys are already going to know because you've been nurses for a while. But obviously, if you have an unresponsive patient, we're going to skip this appearance stage and all of this initial impression, and we're just going to dive right in. The other thing would be crying and upset. We want to try and calm the child down so we can get a clearer picture of what their distress level is or what's going on. And we want to allow that caregiver to stay close by, use tools like toys, comforts, like their pacifier, their blanket, their teddy bear, whatever's comfortable for them, just to try and get that child to calm down a little bit so we can get a little bit of a better assessment of this child. Remember, this is our appearance. This is our view from the doorway. So this is that snap decision that we're able to see, assess, and know kind of how to move forward. The next component is going to be breathing in our initial assessment. Now, one thing I really want to stress with the pediatric population, this is going to be one of the things that is vastly different than the adult population. When children compensate, they compensate with their respiratory system. So in an adult, when an adult crashes, we expect something typically of cardiac origin. With children, it is almost always going to be respiratory origin. So we really focus on breathing in children. We really focus on work of breathing. We focus on the respiratory system a lot, because if a child is going to crash on you, it is typically going to be out of respiratory origin. If you can get them properly oxygenated, if you can get them ventilating appropriately, you can typically reverse what's going on. That is a huge difference between adult care and pediatric care. So you will see some things work a little bit differently when it comes to the respiratory system, our respiratory assessment, and our respiratory interventions for children, because our number one goal is protecting that respiratory system. This is where we are going to see a child compensate first. So for example, in an adult, blood pressure. We start to see our blood pressure going down and we start to see our heart rate rising. Okay, these are indicators to us in the adult population. Something is a little bit off. We need to maybe do some more assessing to figure out what's going on. Respiratory rate is, yeah, in there, but it's not as high a priority as it would be with a child. In the child realm, we're not looking at blood pressure as much. That's typically one of your last vital signs that you'll see start to deteriorate. The very first thing you're going to start to notice in a child is this increased work of breathing. We're going to see them positioning themselves in a position of comfort. So tripod position, or what we call posturing, where they basically push their shoulders back. Let me see if I can turn my video on. Okay, well, let me turn the video on just so you can see what I'm doing here. That's okay. So what they will do is kind of like thrust their chest forward and pull their shoulders back. And what that will do, that's posturing. They're trying to open up their airway so that they can breathe better. Are we seeing a child when we walk into the room who's positioning themselves in a way that would say, I'm having a hard time breathing? The other thing that we're looking at is respiratory effort. If it's normal, we're going to have a regular breathing pattern. We're not going to see an increase in effort. We're going to have passive expiration. This is the abnormal that we need to be considering. Are we seeing nasal flaring? Are we seeing retractions, use of those accessory muscles? Are we seeing that their respiratory rate is increasing? And do we feel like they're having inadequate or absent respiratory effort? So I will send out this PowerPoint as well outside of the video context here, so you can click on each of these links and you can see, what does nasal flaring look like? What does accessory muscle use look like if this isn't something that you've seen before? So we're looking, are we seeing that this child is showing us that they have an increased work of breathing? That's going to be one of our first indicators that our kids are having a little bit of a hard time. The other thing, remember, this is our view from the doorway, so we don't have a stethoscope on yet. Are we hearing abnormal breathing sounds? Are we hearing that wheeze? Are we hearing stridor? Are we hearing grunting? Wheezing is often, think of your asthmatic. Wheezing is going to be your lower airway. Stridor, that's that high-pitched sound that you hear on inspiration. It will be on inspiration. It means they're having a hard time getting the air in. They can get it out, they can't get it in. Stridor is always going to be an indicator of upper airway restriction. So that's going to be basically everything from the clavicle up. This is something we may see more often in our children post anesthesia if they're having any issues with that airway itself. And then grunting, that's that Noise. Grunting is an indicator that a child is having a hard time breathing. If we're noticing any of these are our clues. We need to be calling our anesthesia, first of all, checking with mom and dad to see if this is normal for them. If it's a CP child, if it's a child that has a significant medical history, they may grunt as a baseline. But if this is abnormal for this child, this would be an indicator for us to call anesthesia. Obviously, we will get hands-on. We will assess in greater detail before we call, but these are always going to be an indicator that, I'm having an airway, or not an airway, I'm having a breathing issue. This child is working a little bit harder to breathe. I know that work of breathing indicates that is going to be one of my first indicators that something is wrong. Let's do some more investigating to see what's happening with this child. Circulation, that's going to be the C portion of this initial impression. So view from the doorway, how well is this child perfusing? Are they pink? Are we seeing a pale child? Are we seeing this modeling? This is modeling here. Any of you with children, if your kids have ever gone outside to play on a cold day and they come back in and you see this, that's okay. That's their body. Basically what they're doing is, when you start to see this, this is a defense mechanism essentially, where the body is shunting blood to the core. They're saying, arms and legs, y'all aren't as important because I need to be providing perfusion to my major organ systems. And so in a child who's not chilly, this would be a sign that there might be a problem with our circulation. You'll often see this too in children with like cardiac issues. Any of our kids that have a normal baseline perfusion issue, we can see this, and that's where it's always important as well to ask mom and dad, is this normal for them? Or is this, do we need to be concerned essentially? The other thing, cyanosis. I feel like you all know what cyanosis is. And then flushed skin, flushed cheeks, that could be a sign of fever. These are going to be far less likely that we will see in our environment, but they're on here as abnormals. Petechiae, those little dots, these are all signs that there's bleeding underneath the skin. This is abnormal. So you've got your petechiae, your purpura is going to be a little bit larger, and then you have full-blown ecchymosis. I would be very, very surprised if we ever saw this in our environment. This is typically something you would see in an inpatient pediatric unit. So now from the doorway, does this kid look sick? I mean, we don't have to know a lot about kids to be able to look at him and be like, dude, you don't look very good. So, sometimes it's hard to tell, sometimes it's easier, but I always ask the parent. I always try and make sure that I'm empowering my parents. Like, you are so and so's expert. You know them best. I may know kids, but you know your kid. So is this normal for them? Is this color normal for them? Is this patterning on their skin normal for them? Is this sound that they're making normal for them? If it's not, that leads us to do further investigation. So you can see here, this little girl obviously does not look good. She's got the dark rings under her eyes. Her face is pale. She's looking pretty fatigued, where this is a child you'd expect to be up and playing. This little boy, quite obvious. He's got that nice swelling on the side of his face, some type of cellulitis going on here, probably like a tooth infection, but quite obviously is not feeling well. This is going to be really important with our kids with like those chronic illnesses, because we have visible abnormalities. They might not actually physically be ill, but it's going to look different for us because of those chronic illnesses that they have. Once again, asking mom and dad, is this normal? Okay, so remember, that is our view from the doorway. There's a lot that we can assess about a child in that split second that tells us, hey, I need to investigate further. I need to look deeper into this. Now we're going to move into the interview portion. This is something that in same-day surgery, we are all very, very good at. However, when we're looking in the pediatric realm, there are going to be some things we want to take into consideration that we don't necessarily always have to take into consideration in the adult population. So first and foremost, there's parents now. We're used to having a family member, but in this case, our parent is going to be, for the most part, our historian that's going to be providing us information. So we really want to come in and start visiting with those parents, engaging the child as well. But typically, we engage the parent first. And now I don't mean like talk to the parent for 5 minutes before you acknowledge the child. But when you walk in, hey, mom, hey, dad, I'm Tabby. I'm going to be your nurse today. Who do we have here? and start talking to the child, because the children, for the most part, are going to be looking to their parents to say, this is a safe person, this is a safe environment. And so if we build that rapport with our parents quite quickly, that will help us as well. Our parents are also the one we're going to be talking to. So this is not to say ignore the child for an extended period of time, but really approach the parent. That shows the child that you are a safe person that mom and dad trust, and then engage the child. This typically happens within a few seconds. You guys obviously know, wash your hands, establish rapport. Use touch sparingly at first. Children are taught to be leery of strangers, and we come into a hospital setting and we expect everyone just to be comfortable with us poking and prodding and all of these things. Children are going to be the most leery of this because they do have, for a larger portion of their lifespan, have stranger danger. So use touch sparingly at first. Slowly ease yourself into using touch. Considering developmental stage is going to be important, and we're going to talk about that in a few slides. How do we address different children at different stages of development, and what do we need to share with them? What information is helpful and beneficial to them? Okay, so I feel like we know this pretty well. Using appropriate introductions, assuring privacy and confidentiality. This is the big one, those allow the child to play while visiting. So your assessment in your interview is going to look a little different in your pediatric patient, than in your adult patient. With our adult patient, we can say, okay, sit down. I'm going to put the SAP probe on and we're going to check your oxygen. I'm going to get a blood pressure on you really quick. With a little kid, they're not just going to sit there and let you do those things. They're either going to be a little bit fearful of it and not like it, or they're going to want to play with it. So it's okay to allow the child to stay in a position of comfort. You can do your entire assessment while they sit on mom's lap, while they cling and wrap their arms around mom's neck and shoulders. You can do the bulk of your assessment with them playing on the floor. Allow them to be where they are comfortable and less agitated, in order to get a proper assessment on the child. So when we're communicating with parents, a couple things just to keep in mind. Obviously, always be encouraging. For the most part, parents are pretty fearful of their children having procedures. This is a situation where they are out of control in an environment they're typically the most in control, the care of their child. So really trying to encourage them, letting them know that they're going to be with their child through the bulk of the procedure, that when child is awake, they will for the majority of that time frame, they will be with the parent will be with the child. That's going to help decrease a lot of their fears. If, mom is there and dad can't be there, you can always offer to have dad on the phone while you're going through this information, so that dad is hearing it and is feeling more comfortable as well. Directing the focus. These are a lot of things that we already do when we're interviewing our patients and really doing those question and answers. Yeah, so I'm not going to go through those in too much detail because it's very similar to an adult assessment. Now, when we communicate with the child, it's really important that we're taking into consideration that child's developmental stage. One day I saw someone go into a room to take care of a 2-year-old, and they're like, and now I'm going to get your oxygen saturation. A 2-year-old has absolutely no idea what that means. Going at it from the point of, I have this really cool flashlight and we're going to put the flashlight on your toe. Okay, now we're going to give you an arm hug, and this arm hug is going to squeeze really, really tight. So we're going to play the statue game. I need you to hold as still as you can, using their teddy bear. Who do you think can be the most still? You or your teddy bear? You or mommy? And really using terms that they're going to understand. Arm hug, the flashlight that goes on their finger, really focusing them on the monitor so they can see the waves and see the different colors. So making sure we're doing things in a way that's developmentally appropriate for the child and that they're going to understand, and that's going to put them at ease. So in infancy, really, we're looking at those nonverbal communications. It's that smiling, it's that warm, welcoming personality. It's using a tone of voice that is calming and soothing for that child. Early childhood, now we're starting to communicate one-on-one with them. We're engaging with them. We're, oh, you have Paw Patrol shoes on. Who's your favorite Paw Patrol? Oh, do you like Sky? Do you like Chase? Oh, is that PJ Masks? If you have absolutely no idea, I had one day I was taking care of a little kid. He was like 2, had a TNA, and he kept telling me about PJs. And I'm like, oh, he wants to put on his jammies. And I'm like, well, this is so weird. It's the middle of the day, but we don't have his jammies. And finally, his mom's like, oh, no, no, he likes PJ Masks. And I had no clue what PJ Masks was. It had just come out. So then I kind of opened up, oh, who's PJ Masks? Show me. And, kind of created that rapport with them. So for those of you who maybe aren't super familiar with children's shows or characters, that's okay. Find something to engage with them that will help them to feel more comfortable. Always making sure that we're telling them what they can do or how something is going to make them feel, like no pokes, no owies. Owies are all done. This is just an arm hug. No owies, no owies. I say that a lot to little kids because that toddler age, they know what an owie is. And so if we can reassure them that there's no owie involved, it can help them feel a little bit more comfortable. Always being very direct and concrete in this group of children. If you say it, you got to do it. So if you say, do you want to? Are you okay if I assess you? Are you okay if I listen to your heart? And they say no, you've got nowhere else to go. So it's okay, Tabby's going to listen to your heart now. Okay, Tabby's going to listen to your tummy now. Where's your belly button? Show me your belly button. Doing things like that to get them engaged, but while being very direct and concrete at the same time. When you get to school age, they want to know, they want to understand, what are you doing and why are you doing it? Is it going to hurt? In this age group, this says here that they're very concerned about body integrity. So they're very worried about any harm coming to their physical self. And so it's really important that we're explaining what we're doing and why we're doing it, and engaging them in that process, because that will really diminish a lot of the fear that they may have. Now, in adolescence, we're seeing that they function between that child role and the adult role. We have all seen this with the 16, 17, and 18-year-olds who come in and you're like, oh my gosh, you're 16. Why are you acting like you're 10? Like you're letting mom do everything for you. You will see them fluctuate in 2 ways. One is either going to be very mature and have adult thinking, or they're going to fluctuate into that child stage. It's just a matter of figuring out where they're at and kind of tailoring to that without enabling it as well. I'm not saying allow a 16-year-old to get away acting like a 10-year-old, but just know that this might be a way that they might act. And so really encouraging and empowering them. I had a 20-year-old the other day that he wanted his mom to put his shoes on for him and wouldn't stand up and go to the bathroom. And I literally was just like, okay, we're getting up now. Here, nope, he's got it. He can stand, and really in an encouraging way, really not enabling them to act in a childish manner as well. So adolescents are always fun. You never know what you're going to get with them. This just goes a little bit more in depth into the age specific considerations. So for that 0 to 6 month, once again, they're completely unaware of those surroundings. They don't know what's going on, but this is typically where parents are going to be the most fearful, and a child will feed off of their parents' anxieties. So it's important that we calm the parents. We help the parent to understand what's happening now and what's going to happen post-operatively. Your child is going to come out of anesthesia. I can almost guarantee you there's going to be a lot of tears. It's not necessarily that your child is in pain, it's that they got a whole bunch of medicine and it makes them feel funny and they don't understand why they feel the way they feel. And in many children, that will make them angry. And so they're going to be screaming. That's normal. I don't want you to be concerned when you see this in your child. It will pass. There will literally come a split-second moment when all of a sudden this child you don't recognize turns back into your kid again. And this is normal. Don't be concerned by this. We want you to expect this to happen, but it will pass and it will go away. So helping ease those parents' anxieties, letting them know what is to come, and that will help ease the child's anxieties. Between the ages of 6 months and 4 years, this is when we're going to be at the height of stranger danger and also at the height of separation anxiety. So once again, in that toddler stage, really engaging them, helping them to understand and allowing that parent to be close by as much as possible, because that will help them to feel more comfortable. Post-operatively, like we said, you're going to see a lot of that emotional upset. We've all heard it in the hallways. You're also going to see behavior regression, letting parents know that many times parents are quite embarrassed by the way their child is acting, because like, this is not my kid. Like, why is he doing this? Like, don't do that. Don't do that. Don't do that. You know what? We just tell them, hey, this is okay. We expect this. This is normal behavior. We just go with it. It'll all be fine. We're not judging your parenting in any way, shape, or form. This is normal behavior. And if we can help parents to feel better about that, it really goes a long way. Um, so 4 to 6, this is when we want to be explaining those processes again. They're still going to have that fear of separation from their parents. They're going to be concerned about body integrity. So this is where it's important that we're explaining to them what is going to be happening, what they can expect, what we are doing. When are we going to see mom and dad? When might mom and dad be gone? I know so far I've realized we really work hard to have the parents separated from the child as little as possible. And I think that's very good for these children because it reduces that separation anxiety. Um, Once we get past that age of 8 and we start moving into adolescence, they're more tolerant of separation. They're not as afraid of being away from mom and dad, but they want to understand. They want to know what's going on. It's important that we remember that they do take everything very literally. So we need to be careful with the terms that we're using, to make sure that they aren't terms that are going to cause more fear, but are very specific to what is going on. We're also going to see at this stage of adolescence, we're starting to see, sexual characteristics developing. We're starting to see, the breast buds forming. We're having pubic hair. We're starting periods. Our voices are dropping, those kind of things. And so being very cognizant of the fact that they're going to be very self-conscious, that body image is a big thing. Self-esteem is a big thing. And so just be aware of that when you're asking questions, when you're having them change, do you want mom and dad to step out? Those kind of things, so that we're maintaining their dignity as well, because they're all very fearful of that loss of dignity, that loss of control of their body. Okay, so pre-surgical questions. In addition to the questions we already ask, there are some others we need to take into consideration with children. These are more questions that are helpful, but I wanted to list all of the options here so that we were aware of what are some additional things we could be asking or should be asking. A big one, and we've noticed this with several of our Murphy patients who are in the custody of CPS or at the Ann Carlson Center, figuring out, okay, who's here? What's our family structure? Is this mom? Is this dad? Is this grandma? Is this grandpa? Is this foster parent? Is this social worker? Who do we have here with us today? And who can legally sign documents for this child? Who can receive medical information? Sometimes, and typically this will be in their chart, typically this will come before, in pre-admissions. I would hope this information would be made available to our pre-admission staff, but questions that we should be asking, who can sign documents, who can receive medical information. Typically, if mom and dad are both in the same room, it's easy. You can assume they're both there to receive medical information, but we do need to be careful, especially if CPS is involved. I've talked with Sharon about us doing some additional training as far as this is concerned, so that we're making sure we know who to call and we know the guidelines that are in place for signing documents and receiving approvals, especially if CPS is involved. If we're dealing with an infant, it's important to know delivery history, were they term, were they preterm, then we can know that adjusted gestational age that's necessary for anesthesia. Other questions I've been liking to ask in the pre-surgical realm is, do they use formula? If so, did they bring it with them? Are they breastfeeding? How much, how often? Are they doing table foods? What are some of their favorites? And writing that on their sheet so that when the post-op nurse gets this patient back, okay, I see they love pudding. They love ice cream. I'm going to have ice cream available because one, that's one way I can win them over and make a friend. But two, I need to make sure this kid is eating and drinking feeding. And if I already know what they like, I can be prepared to bring that into the room for the child. This was a big one too with the formula piece, making sure that parents, that they're showing up to pack you with formula and a bottle, because oftentimes when that child wakes up, that's the comfort mechanism that they're going to want. And so maybe not leaving the diaper bag in the room that they're going to be coming back to, but do they want to bring formula and bottle with them, and therefore their diaper bag with them to the waiting room so that that's ready and available in PACU. Other questions, growth and development. So these might not always be questions we ask directly to the patient, but questions we're maybe asking ourselves. Where are they at developmentally? Are we seeing things? Are there delays or concerns that we should be aware of, especially in our children who are coming in with known developmental delays? It's not bad to ask, do they take oral intake? What can they do orally? Do they speak? And asking some of those questions. I think sometimes we steer clear of those questions because we don't want to be rude or we don't want to, make it uncomfortable. But those parents typically really enjoy when we ask questions about their child, to understand their child and to engage with their child in a way that's appropriate for them. Others, diaper size and weight. We'll obviously get weights on our children always, but having diaper size on there is helpful as well, especially for those kids who are going to come back double diapering. Then we have our supplies on hand for that size that they wear and one size larger. Asking about any comfort aids, blankets, pacifiers, stuffed animals, making sure that those go with mom and dad so that they can be in PACU afterwards. I don't know if we do this at Sanford, but I've seen it at St. A's and some other facilities, that if a teddy bear goes into the OR, the teddy bear often comes out with similar bandages compared to the child, so that they're matching. It's kind of fun. The kids really like that. Or you can put Band-Aids on them, that kind of thing. And then last but not least is just preferences. Do they have any food preferences, textures? You guys probably all remember the little guy that I had who was adamant he was not putting his gown on. And as long as that gown was on, he was having a fit. And so we let him wear his own jammies until they could gas him to go to sleep. So is there a texture thing that we need to be aware of? And really just trying to understand what are their specific fears, anxieties, and concerns, so we can start to address those. If we know what's causing concern for these, especially those school-aged kids, we can speak into that and we can help alleviate those fears that are maybe completely unfounded. All right, now our head to toe assessment. So we're going to kind of brush through this one a little bit quicker because the head to toe assessment on a child is going to be very similar to that of an adult. We will touch on the things though that are a little bit more, we look at more with children or might be slightly different. So vital signs, we all know vital signs. We all know how to get vital signs. However, in infants, you may have to observe abdominal movements. Children are belly breathers. Babies and toddlers are belly breathers typically until about the age of like 2 or 3. Little boys will be belly breathers typically up until about 4 or 5. So if you're trying to watch for chest rise, you might have a harder time. So just remembering that when you're counting your respirations on kiddos, if they're, in that 3 and under stage, you might be looking more for abdominal movement and belly breathing as opposed to that primary diaphragmatic movement that we see in adults. Pulses, this is a big one. Big difference in children. So radial and pedal pulses, you typically will not feel in a child under the age of 2. That's not to say that it's unheard of, but you typically will not get a radial or pedal pulse in a child under the age of 2. Their vasculature is not developed enough to be able to feel it. So on those children, you're going to be doing a brachial pulse and you'll be doing femoral pulses. Once they get to age 2, or if they're a really, really big 1-year-old, you can always check and see if you can feel those pedal pulses or those radial pulses, but just know and do not be concerned if they're under the age of 2 and you can't feel those. That is developmentally and physiologically appropriate for that child. Um, Apical count for 1 full minute in infants and children. So the reason that they recommend this in infants and toddlers is because it is actually normal for an infant and a toddler to have an irregular heartbeat. And so that's why they recommend a full minute. I will be very honest with you, in pediatrics, we listen for 30 seconds. I don't think I've listened for a full minute on a kid since nursing school, or unless it's like a NICU environment or PICU environment. But the reason why they want it to be a longer period of time when you're listening for those heart rates is because their heart rates are irregular, and that is normal. Temperature, fever in a child is considered 100.4 or greater. Febrile seizures are possible around 102.2. However, you do not get to brain damage level until you're about 108. If you have a neurologically appropriate child, their brain and body will physically not allow them to get that high. There's a huge misnomer in healthcare right now and really across the United States, that fevers are bad. They are not. Fevers are our friends. Fevers are the body's natural immune response to helping children get over illnesses. We really should not be seeing children with fevers in our area. If they do, they're probably sick. We definitely need to let anesthesia know, because I'm not sure that that child is necessarily appropriate for having same-day surgery. But that is up to the provider's discretion, obviously not ours. That being said, that fevers are our friends. Any of you who are interested, I can send you some really amazing information, facts and myths about fevers that Seattle Children's Hospitals recently put out. It's super helpful, really informs your care as a parent, especially. But healthcare, as always, we are behind the times. So fever is 100.4, and typically that is the number that you would begin to treat with Tylenol. And if they're over the age of 6 months, ibuprofen. Birth to 2 years, your ideal blood or temperature is going to be axillary. Most hospitals are moving to temporal, even in infants. I'll be interested to see what the research really has to say about that. But what we are doing with our temporal is actually what we're seeing in most pediatric units across the country. Literature still supports axillary, though, for birth to 2 years. Anything older than that, you can do tympanic or temporal. We obviously only have temporal, so that is what we will use at our facility. Blood pressure, you're going to see the exact same thing. It's important as we would see in adults. If the cuff is too small, you're going to get a false high. If it's too large, you're going to get a false low. Keep in mind, if your child is anxious or if they are moving all over the place while you're trying to get that blood pressure, you're going to get probably a higher reading than you need. So the best thing to do is kind of put it on and try and hold that limb as still as you possibly can. If they're old enough to understand to hold still, play that statue game with them. Okay, we're going to give you a little arm hug. Okay, we're going to do our arm squeeze. I need you to hold as still as you can. Try and be a statue, and really try and play that statue game with them and see if that will help. I've noticed a lot on a lot of our patients preoperatively, we've not been getting a blood pressure. While blood pressure isn't always our most important vital sign in children, it is imperative that we do have a baseline. So we do need to be getting one or trying to get one preoperatively if we can. Keep in mind, though, you can always chart if your blood pressure is elevated for that age group. Chart in just the comment, child upset, child crying, child moving, so that they understand why it is a little bit elevated, or wait until they've been sitting for a while, they're a little bit more calm, cool, and collected, and then go ahead and put that cuff on. These are the PALS vital signs. This is the ranges that PALS recommends. Honestly, you can look at like 4 different places to see what our normal ranges are for children. Unfortunately, it's not completely standardized. These are PALS. What we have on the back of our name badges, if you do not have a vital sign sheet on the back of your name badge, you can get those from Sharon. They are laminated and in her office. And what we have is very similar to this and is appropriate. So these are here for you. You will notice your blood pressures are going to be significantly lower, your heart rates are going to be higher, and your respiratory rates are going to be higher the younger the child is. So a couple different pain scales. This NPAS is what we are going to use on newborns and infants, okay? So this is typically 0 to 1 month. We use the NPAS scoring. So you can see it's a neonate. 0 to 1 month, we would use NPAS. This is actually available in Epic No need to memorize this. If you choose NPAS, if it's a 0 to 1 month old, typically I don't think that that age child would be coming through us anyway, because typically those children recover in NICU, actually, not even on PEDS. But it is available in there so that you can see that scoring tool. The one we are going to use the most frequently in our area is going to be FLAC. Again, it's a step, so there's 3 stages, 3 steps to each area. We're looking at face, at legs, at activity, at cry, and at consolability. We use this for basically over 1 month to about 7 years, or in any child who's unable to communicate their pain. And so this system is going to be in our EPIC charting as well, so you can kind of review that there. The next one, the Wong's Faces scale. So these, I did print and laminate them. Any child who is, I will be honest with you, I have never seen a 3-year-old who can actually do the Wong's Faces scale. I've never really seen a 5-year-old who can fully understand the Wong's Faces scale, but technically they say it's for 3 and older. I believe we're going to be putting it in the charts of all of our kids 5 and older, I want to say, or 5 to 12, I think is what we decided for our kids. And this literally is just a scale that kind of shows them the faces and will kind of give them an indicator of what is their pain. Once again, trying to make sure that it's a child understands it. I had a kid one time in nursing school actually who was like, I'm a 3. I'm a 3. 3 is me. I'm a 3. I'm a 3. Or no, it was 4. I'm a 4. I'm a 4. 4 is me. 4 is me. And we could not get this girl's pain under control. And which in hindsight, 4 is really not that bad, but whatever. So the little girl gets up to go home and she walks right up to the board, points at the number 4 and says, see, Daddy, it's 4 like me. I'm 4 years old. And we're like, oh my gosh, all day she's been saying that she's a 4 because she is 4. So keep in mind, the children have to understand the scale to use it. If they don't understand the scale, FLAC is going, or they can't actually express their pain, FLAC is going to be the scale that you want to use. Anyone older than typically like that 7 to 12, you really want to see where anyone older than 12, you can start to use that 0 to 10 scale if they can understand what it means. Okay, so in our assessment, we're looking at head, neck, and eyes. This is going to be exactly the same as the adults where we're observing for symmetry, any obvious lymph nodes, or trachea deviations. This would be incredibly rare in our environment. Eyes, are we seeing any discharge, any goopiness in those eyes? And in a lot of our kids, we might, especially if they're going in for the tear duct surgeries, if they have a clogged duct, you're going to see really goopy eyes. The reason I put this on here, though, is I wanted you guys to be aware of the fontanelles, just as a reminder that anterior fontanelle is going to still be open from 12 to 18 months, whereas your posterior fontanelle, that one on the top of the head that's much larger, that closes at 2 months of age. In a child with bulging fontanelles, that can be an indicator that there's increased pressure. Cranial pressure. If they are depressed, that's a sign of dehydration. So we want them to be soft and we want them to be flat. Again, nose, mouth, throat, ears, this is all going to be the same again for children. We want to save this for last if possible, because with kids, we want to go from least invasive to most invasive. So what can I do hands off and then get more invasive as you go? Typically, these assessments are more invasive because we're looking in nostrils and things like that. And so just be cognizant of that. Again, I would be very surprised if we were looking in ears and noses. That's not typically something we do in our environment, but just be aware of that. The big thing that's important is in this 0 to 2 month stage, these little babies are what we call obligatory nose breathers. They do not breathe out of their mouth. They only breathe out of their nose. And so as such, we need to make sure that those nasal passages are open. So either bulb syringing or wall suctioning so our wall suction that we have, we've all seen the big old yonkers. There's actually an attachment that goes on there. It's literally the best invention ever. I wish I had them at home when our little ones are sick, because it's amazing, but they're called little suckers, and they're literally tiny little suckers that you stick in their nose attached to the suction, and it will suck out all of the snot in their nose. It's amazing, very cathartic. But anyway, important to know, children 0 to 2 months are what we call obligatory nose breathers. We need to make sure that those nasal passageways are open so that they're breathing effectively. Breathing. Now, we've stressed the importance of breathing. Remember, if children are going to decompensate, they are going to try to compensate with their work of breathing, which means they're going to start breathing faster. We're going to start seeing things like nasal flaring, retractions, head bobbing, seesaw respirations. If you click on this video link, you will actually see what those seesaw respirations are. So when we're seeing those signs, those are indicators to us that this child is having a harder time breathing. They're compensating for something. Now, in an adult, if an adult is satting 93%, we're typically not going to put oxygen on them, right? That would just be a little bit silly. We wait for those levels to drop below 90. It is not the same in children. If you are seeing a child who is showing you that they have an increased work of breathing, you have an increased respiratory rate at rest, you are seeing nasal flaring, retracting, you're hearing respiratory sounds, those kind of things, that is a child who's compensating. If we can help that child by putting a little bit of oxygen on them, doing some of the work for them, we have just saved ourselves and bought us time to figure out what this child is trying to compensate for. Is it an infection? Is it something else that's going on in their system? So keep in mind, we in PEDS will oxygenate children based on respiratory symptoms, not always based on oxygen saturations. You will see respiratory symptoms in a child oftentimes before you see their oxygen level dropping. Not always, but oftentimes. So if you have a kid who comes in, comes back from surgery, and you're seeing an increased work of breathing, you're seeing, especially if it's retractions, head bobbing, you're hearing those breath, those audible breath sounds, the stridor especially. We want to be putting oxygen on those little guys to help them compensate, to help give their body a break so they're not working so hard to breathe. And then as they begin to wake up, as their little lungs start to kind of get over that anesthesia, we'll wean them off of that oxygen. But this is a very big difference in kids compared to grown-ups. So once again, belly breathing, we typically see belly breathing in our infants up to toddlers. Once you hit about age 3 in girls, you're going to see them move to chest rise breathing or that diaphragmatic breathing. Boys, it can be up to age 4 or 5 before they stop belly breathing. You guys obviously know to check for symmetry of chest expansion. So air movement, this is a big one. Kids have tiny little chests. They have tiny little bodies, especially babies. That's going to cause sounds to be transmitted all over. So in your littler bodies, to listen to the base of your lungs, you're actually going to listen in the axilla. So for the uppers, you'll listen in the same spot that you normally would on an adult. But in your toddlers, and especially in your babies, you're actually going to listen kind of in the armpit region, a little bit lower, probably even with the nipple line, but into the armpit. That's where you're going to listen for your lower lobes, for those lower breath sounds. Okay, it's important to stop, close your eyes, listen closely. They do have an increased respiratory rate, so listening for that inspiration, that expiration, and comparing the intensity of those sounds, comparing your air movement. Prolonged expiratory phase can be a sign of difficulty breathing, and especially like an asthmatic or something like that. So in kids, we really focus on breathing. So lung sounds, again, what are we hearing? Is it upper? Is it lower? So that kind of clues us into what medications are going to be most effective for that child. If it's upper, we're going to be using things like racemic epi. If it's lower airway and wheezes, we're going to be using things like albuterol or duonebs to treat that. Okay. This is something that is different in children than in adults. A normal oxygen saturation for a child is 92% or greater on room air. So different than adults where it's 90 or greater, children is 92% or greater. We already talked about this, that if they're in distress, they may maintain their oxygen saturation but have an increased respiratory rate and effort. If that is the case, we may need to put some O2 on them to help decrease that distress. And then obviously make sure your machine's working. We obviously all know to look for a good pleth because kids move around so much, you don't always know if you're getting a good oxygen saturation if you're not looking at that pleth. Okay, circulation is going to be the same in your adult and in adults as it is in kids. You're listening to heart sounds, listening for murmurs, things like that. Pulses, we've talked about this as well. In your infants, you're going to be doing your femoral and your brachial pulses. On your older children, your central pulse would then include that carotid. Okay, we do not check carotids on infants. It's brachial and femoral. Now, with your peripheral pulses, again, remember, you are not typically going to feel peripheral pulses until about age 2 to 3. So that's your pedals, your radials, that kind of thing. Weak pulses in a child is always concerning. It is a precursor to cardiac arrest. We have our little 90-year-old grandma who comes in and yeah, we got a Doppler feet, or her pulses, her pedal pulses are just a little bit diminished. Are we overly concerned? No, she's 90 and she probably has every medical acronym in the book. We're just happy we can feel them and we don't have to go get the Doppler. In a child, if they're age appropriate to feel pedal pulses or radial pulses and we feel them and they're faint or they're weak, that is always, always, always concerning. Okay, pulses are an indicator to us oftentimes in children, not oftentimes, they are an indicator to us as a precursor to cardiac arrest. So something we need to take into close consideration. A child this sick should not be in same-day surgery. A child this sick will most likely be already up on the floor, but it's important to know this information nonetheless. All right, capillary refill in children is less than 2 seconds. So adults, it's less than 3. Kids, it's less than 2. One other thing that just, of course, has to be slightly different in children. Looking at skin color again, we've talked about all of these. Are they pink and they warm? Are they flushed or lethargic? Cool, pale, dusky, mottled? All of those would be things that would clue us in that we need to be doing deeper assessments on the children. Once again, blood pressure is an unreliable indicator of status in children. Typically, it's going to be one of our last vital signs that we see to deteriorate, and children move around a lot, so sometimes it can be hard to get an accurate blood pressure. That does not mean we don't do them. It essentially just means that it's not going to be our first warning sign that we see. We should be seeing other things before we start to see a blood pressure drop. Chest and abdomen, really nothing too different here in children compared to adults. We typically listen on children because they do have that irregular heartbeat. So just listening for a longer period of time, that 30 seconds to a minute, just to ensure that we are getting an accurate heart rate. There's lots of things that can cause tachycardia. There's lots of things that can cause our vital signs to be higher in children. You can see them listed here: stress, fever, pain, medication side effects, shock. So we really need to take into account our whole child when we're looking at these vital signs as well. It never hurts to get a second set of eyes too. If you're just unsure about something, grab someone. That's always a good idea. You all know that. So GI, it's going to be the same as it is in adults. With our kids, though, we're going to be asking a lot of those questions about the tubes. Do they have a PEG? Do they have a Mickey? Especially with those Murphy patients, or those seems to be a lot of the kids that we get. We seem to get a lot of complex kids in our area outside of our tubes in our ears. So just making sure that we're asking these questions like, what do they have? What type of PO intake do they take? What is their appetite like? What types of foods are they eating? What type of formula do they use? Are they breast? Are they bottle? Are they on table foods? What are some of their favorites? Going into some of those pieces too. Musculoskeletal, the big thing in this is just really making sure that we're symmetrical, equal. We know all of this, checking for swelling and edema. Education a lot with kids on casts and splints and things that we can do to help keep those casts and splints on as long as possible without getting broken, because summertime is coming and that means we're probably going to see lots of children coming in with broken bones. It's just like the time of year. And so parents always have questions on, okay, how the heck do I keep my 4-year-old from not using this arm? Or how do I keep this cast intact? So making sure we're providing good education on casts and splints. We don't use IV boards at our facility, or not that I've seen, at least in our environment. Um, they're very helpful. They keep kids from, moving in a way that would occlude their IV, but our kids typically don't have them long enough to really need them. Last but not least, these are my references. So one thing I just want you guys to keep in mind with this as well, when we're talking about the pediatric patient, the question I've gotten before is, when does peds end and adult begin? So we typically move into more of an adult assessment model when we are seeing those sexual characteristics coming into place, those signs of puberty. So that would be breast bud formation, pubic hair, their voices dropping, things like that. That's typically when we're moving into a more adult style of assessment of a child. So that's just kind of that dividing line. So most of what we've talked about today is going to be that younger child, that prepubescent child, really focusing on infants and children. As I said, we are going to be putting together some Q&As. They'll be about, I believe they're going to be 30 minutes in length, where after you've reviewed this information, you can come and ask away. We'll be keeping track of all of the questions and all of the answers, and then I will actually submit an FAQ afterwards with all of the questions that were asked across all 3 or 4 of the sessions and what the answers to those are. So you don't have to worry like, oh man, they didn't ask that question in my area, why, in my class or my question and answer, but man, I really wish I would have known. We'll have that information made available to all of you. I really hope that this was helpful and beneficial. As always, please, please, please always feel free to come to me to ask questions. If you're unsure about something, I'm always happy to jump in and help out. So I hope that this information is helpful to you guys. And like I said, please don't hesitate to holler if you have any questions.